I'm going to talk about the global burden of cardiovascular disease, and I'm going to try and divide this up into 3 general learning objectives. The first is what is the global burden of cardiovascular disease? And I think a really important part of that comes up frequently is how can we possibly even know that? It's tough to think about studies even in individual populations sometimes, and to talk about measuring something for the planet overall. I want to talk about the history of the epidemiologic transition and population-based studies of cardiovascular disease, because I think they set sort of the foundation for what eventually has become the global burden of disease study, which is, for the work we do, our primary tool for answering this question: what is the global burden of cardiovascular disease? I want to talk about major global trends in atherosclerotic vascular disease, health overall, and the risk factors that are driving these conditions. And then I want to end by talking a little bit about the solutions that are available to us for solving some of these problems. So what is the global burden of cardiovascular disease? And even more importantly, why do we care? A lot of this work is framed by earlier work around what is often referred to as the epidemiologic transition. And this is potentially a phrase that for this audience, for you guys, may be quite familiar, but I think it's really useful to just touch base on where this even came from. This is the work of a gentleman named Abdel Amran, who really, I think, invented this concept of an epidemiologic transition, which has now been used really in many different ways and often gets thrown around as a term to apply to a lot of different things. But it's interesting to go back to where it came from. This is his original paper. And what he did was working in England and Wales and London in particular, because these were places where there were death certificates going back to the 17th century. He just tabulated something super simple: the proportion of causes of death. And you can see that infectious and diarrheal deaths in his paper, in which he reported on this, accounted for the majority of 17th century deaths in London, maybe not that surprising, and that heart disease was a very, very small proportion of those deaths. And then over time, you can see that infectious diseases decreased and heart diseases and strokes increased. And so this is oftentimes what gets referred to as an epidemiologic transition. It's actually not what Abdel Amran referred to, though this was part of this initial work. What he was really talking about was this demographic transition. And here he showed it in England and Wales, Japan, what he called Ceylon, which is Sri Lanka, and Chile. And it was a very simple observation, sort of amazing that it hadn't been well documented in the scientific literature until the 60s and 70s, which is that as populations increased, birth rates decreased, and death rates declined. And this observation was really an attempt to show that demographic change, driven by changes in society related often to industrialization, were fundamentally tied to mortality rates, but also the composition of causes of death. And this kind of information turned out to be, one of the ways that governments tried to think about what they should do in terms of health policy, and underlined a lot of hugely impactful decisions that were made in the 20th century. For example, the policy of limiting the number of children you could have in China for many decades, just as one example. There are a number of studies about cardiovascular disease that have built on this idea that comparing across countries, that geographic comparisons can drive our understandings of health. And I want to touch on those as well, because they end up forming what I like to think of as the foundation for the work that we're now doing in the global burden of disease study. Some of you may be familiar with what I like to think of as really the original cross-national study of health, and in this case, cardiovascular health, called the 7 Countries Study. So there were a number of investigators at the University of Minnesota who, coming out of their experience actually being medics in World War II and being stationed at different places in Europe, and just having observed these very different rates of atherosclerotic disease, proposed very interesting hypothesis, at least at that time, which was that serum cholesterol might explain rates of coronary heart death rates. And here you can see, published in the late 60s, one of the result papers from Ansel Keys' work. He really led this idea that we should think about cholesterol as a potential driver of human health and coronary heart disease in particular. And he did that simply by collecting really high quality data on cholesterol levels and death rates across these different locations in Europe. In the late 70s, the MONICA study, organized through the World Health Organization, tried to look across more than 20 different locations at heart disease and stroke rates. Some of these sites are still enrolling and actually reporting results, though most of them have gone away. There was a site in the US, there was a site in Beijing. So it was really expanding this idea that we can look across countries at heart disease patterns and moving beyond Europe in particular. And it was actually driven by a really interesting phenomenon. So it was not hugely high rising rates of heart disease that drove the origin of the MONICA study. It was actually that in the mid to late 70s, a couple investigators began to note the very beginning of the decline of heart disease rates. And it was the idea that there might be drivers of this decline in some places that could then be used to help improve policy and interventions in other places. So if we think backwards on like 30 years of declining heart disease rates in high income countries, sometimes referred to as sort of one of the great public health accomplishments of the 20th century, it was actually the very beginning of that trend in the 70s that led to the MONICA study, and actually was the beginning of some of the sort of standard approaches we now have for even being able to track heart disease death rates in populations. Interheart, really important study, reported in the 2000s, looking across now 50 plus countries. Really nice approach. It was a case control study. So if you're going to work in 50 countries, nice to use a cross-sectional approach. A lot of limits to case control studies. But this was really the first study that showed that what we thought of as the traditional risk factors for atherosclerotic vascular disease, coming out of the work from studies like the ones I've mentioned, and also the Framingham study in the US, looked to be very similar across all of these other countries. The risks associated with tobacco and cholesterol and blood pressure and a number of other common exposures that we knew about were actually very similar. And so this was one of the major drivers in the idea that we might actually think about a global approach to reducing coronary heart disease and stroke, because the risks driving it actually looked very similar in different places. And now, sort of moving into the time of big data and the ability to handle really large numbers in studies, we've started pooling studies. This is work published in the Lancet maybe 6-7 years ago, with 1.8 million participants pooling many, many cohorts together. So these kinds of studies I think of as sort of setting the stage for the global burden of disease study, which is the work I've been fortunate enough to be involved in for the last 6-7 years now, and I'll spend a little time sort of diving into with you. So it's important to remember as we look at these sort of massive meta-analytic enterprises, these pooling studies, that somebody had to go collect the data. And these are photos actually from the 7 countries study of the original surveyors. This is on the island of Corfu. It looks delightful, actually. We'd probably all volunteer for this job. And they are going out to villages in Corfu to actually survey the population, to get samples of blood pressure and cholesterol, and actually try and interview household members around deaths to identify potential heart disease and stroke deaths. So this is the beginning of what they ended up calling the hot and cold pursuit method. So they weren't just relying on hospital statistics or vital records, but they would actually go out into communities and build what ended up becoming known as verbal autopsy, this idea that you could do a household survey and try and identify the causes of death in different places. A lot of this information has formed the basis for our understanding of the causes of death in very resource limited settings. And because of the expansion of not just traditional vital registration systems, what we think of as death certificates or birth certificate systems, but also these sampling systems in China and India and across sub-Saharan Africa and a whole number of other places, in the 1980s, there was the idea that we should try and actually quantitate the death rates for many, many different diseases, and potentially, more than just death rates everywhere. So the global burden of disease study really came out of these efforts, and it's a study that's been going on since the early 1990s. And here's sort of the way we think about it. It's a systematic scientific effort to quantify the comparative magnitude of health loss from all major diseases, injuries, and risk factors, with a goal to inform decision makers at every level, so not just national or global, but local and regional as well, so that decisions are ultimately more evidence-based. So if any of you are familiar with sort of the evidence-based medicine movement that started in the 80s and early 90s, this is, I think of as sort of like a public health version of evidence-based medicine, evidence-based public health. It employs a range of statistical and geospatial modeling techniques to try and produce estimates in places where data is even quite limited. It produces results for every country in the world, and in fact, for large countries, subnational, what we'd call state or province level estimates. And it produces a time series from 1990 to the present. It's actually not like a traditional research study in the sense that it doesn't get started and then finished and then you're done. It's an ongoing effort. And in fact, we reproduce that time series from 1990 every year because new data shows up, but also because we improve our methods. We look at 300 plus separate diseases, 80 plus risk factors, several thousand health states within each disease category. And then the findings are reported in scientific journals and policy papers, and working directly with countries to move this evidence into their decision-making process, as well as with a range of online data visualizations. I'll show you what some of those look like because we've put those out on the web, and you can look at them on your own as well. I know you are all, for the most part, research scientists, and so I want to touch on methods. I'm not going to delve necessarily into all of the details, but I think it's important to understand our general approach, which is to collect all of the available population health data in the world, apply a range of geospatial epidemiologic modeling techniques, and then produce estimates for all of these locations. Very importantly, we include uncertainty intervals, which have not traditionally been a big part of health statistics, but we think that's a really important way of communicating transparently the strength of the evidence and also the gaps. There are obviously massive gaps in terms of data that's not actually available to us in many places. We try and be very transparent about the data that goes into these models. If you go to what we call the Global Health Data Exchange, or GHDX, publicly searchable website. Also a nice place if you're trying to jumpstart your literature review. We're always doing large-scale prospective reviews of the literature, and you can search by country or disease across a whole range of different parameters. And actually, you can see all of the data sources. There's about 50,000 sources in it now. And so that's one way of seeing what goes into the models that we're building to try and get at these patterns of global health. This kind of work I call global team science. There's no way this could be done by a small group anywhere, and we now have thousands of collaborators. This is just a map of how many people in different countries are contributing to the study. I'd say this is similar to what goes on in large genomics collaborations, where we see many thousands of scientists working together. It's what goes on in astrophysics now, where you see many thousands of people working together. And it is really the direction of a lot of this kind of global science, which is that we need to involve a lot of people, and we've had to actually develop methods and web-based platforms. I mean, there's a whole range of tools that didn't exist that we've had to create to even allow this kind of research to continue. We have teams of individuals who are just spending their time maintaining these relationships, helping people communicate, and making sure that people can stay involved. The paper that people often see related to the study is usually in the Lancet. We have an annual issue of the Lancet dedicated to the global burden of disease study, comes out at the end of each year. There's hundreds of other papers that come out from the global burden of disease study each year, but if you're looking for sort of a good overview paper, then if you go to the Lancet, you can find there are 4 or 5 papers that we use each year to pull together sort of the high level results. And when you look at what comes out of the global burden of disease study, you'll find traditional metrics that'll be familiar to all of you who are epidemiologists, things like incidence and prevalence related to death rates or non-fatal disease events, but we also try and produce what we call summary metrics of health. These include things like years of life lost prematurely or years lived with disability. And those are 2 really key ones, because if you add them together, you get disability adjusted life years, which are, we think, a really important central measure of total disease burden that pull together the losses of early death, as well as the disability accrued by people living with chronic disease. Healthy life expectancy is another interesting one. You may be familiar with life expectancy, crops up in the paper all the time, gets reported really commonly, a common demographic summary metric. Healthy life expectancy is really important as aging increases in many countries. People are living in states of chronic disability. Healthy life expectancy is how many years you can expect to live in perfect health. So it's a really interesting and useful summary measure as well. If you take all of the disability adjusted life years or all of the deaths or all of the health events in the world in the global burden of disease study, you can divide them into three big basic buckets. And this is something we can do because the study is trying to produce mutually exclusive, collectively exhaustive counts of health events in every country in the world. And here you can see non-communicable diseases. CMNN are communicable, maternal, neonatal, and nutritional deaths, and then injuries in green. So this is our best attempt for our most recently published results in 2019 to try and estimate the number and then the relative proportion of deaths. So you can see that non-communicable diseases are contributing the majority of deaths globally. But it's important to understand that the global burden of disease study, the reason it's able to do this is actually because it's not one study, it's better thought of as hundreds and hundreds of studies running in parallel using common methods, common tools, common case definitions so that we can aggregate everything together. And this is just an aggregate picture. If I unmask this, you can see that this is actually what's going on, which is we have research teams that are focused on particular conditions. So my team is looking in that upper left-hand corner, running projects looking at all of these specific cardiovascular conditions. And in the end, we're then able to pull everything together into this big picture. If you go to the global burden of disease compare website or GBD compare, if you just search that, GBD compare, you'll actually find an interactive version of exactly this figure that you're looking at now, and you'll be able to play around with it. You can look at this pie chart. It's a squared off pie chart, so it gets called a tree map, but you can look at this view as well as many others of global patterns of health. You can also pick any country in the world and see what this looks like in the US. You can look specifically at US states. You can look over time and see how the blue part of this picture expands over time. You can look separately by sex, and you can zoom in on any of these diseases. And so a nice tool as well if you're working on trying to describe a disease that you're building a research proposal or a study around. For our cardiovascular disease work, we spend a lot of time thinking about case definitions. If you're going to bring together many different data sources, you want to make sure you're comparing apples to apples. And that can be very challenging. As you all know, we have many different ways of describing and defining diseases, and we spend a lot of time trying to make sure that we line these different conditions up. And if we have studies that have used different case definitions, we actually try and build statistical models to see if we can correct for different approaches to measurement. For example, if we have electronic health records from a country that are coded to ICD-10 codes, and then we also have health exam surveys that have obtained self-report, and then we have other registries that are using more clinical measurement approaches, we try and line these up and see what kind of biases might exist, and then we might see if we can aggregate them or potentially not do that if they're too different. You can see for ischemic heart disease or coronary heart disease, we look separately at acute coronary syndrome, stable angina, and ischemic cardiomyopathy or heart failure due to cardiovascular coronary disease. For peripheral arterial disease, we restrict our study to those where ABI was measured, ankle brachial index, and where it met the standard criteria for peripheral arterial disease. And we do this for many conditions and then aggregate this. So I'm just showing you sort of at the very end of the process where from our models, we can estimate the number of prevalent cases. And I'm just showing you that here. For example, 126 million cases of coronary or ischemic heart disease in the world in 2019. But that's restricted to these subsets of case definitions. We know that atherosclerotic vascular disease occurs in actually almost every adult in many, many countries. But meeting our strict clinical criteria for these different disease states, we get at these prevalent case numbers. And that's one of the ways we work to try and make sure we're producing comparable estimates between different countries. I like this figure. It's a way of looking at patterns of mortality globally by age and by sex. We sort of call it the butterfly picture. It tells us a couple important things. On the y-axis, you can see age starting from neonatal 0 to 6 days at the very bottom, all the way up to greater than 95 years at the top. And on the x-axis, you can see just the numbers of deaths. So these are just counts for females on the left and males on the right. You can see the large number of neonatal childhood infection and then actually adult trauma, predominantly male in green here, as people age. And then you can see this increase in blues of neoplastic diseases, so malignancies or cancers, cardiovascular diseases and chronic respiratory diseases, and then shifting, given very large increases in dementia as a cause of death at the oldest ages, shifting towards predominantly female deaths at the oldest age groups. So understanding how death patterns and causes of death change by age is a really useful feature that we can pull out of this consistent approach of the global burden of disease study. This is another nice feature of the study, which is we can look at these different patterns by different levels of development within countries. So let me just walk you through what we've done here. Here, these are 5 identical figures. Each figure shows years of life lost prematurely as counts on the y-axis, and years on the x-axis from 1980 to 2017 in this case. Each of these panes is identical except that they show different locations in the world, and we've taken the countries of the world and divided them up by what we've estimated and called the socio-demographic index, which is a mixture of income, education rates, and fertility rates. So you can think of these as sort of the World Bank classifications, but it's a lot more useful because they change over time. Countries become wealthier, and so they move between bins. So we always know that in any given year, all of the locations in each pane are at that level, in this case, that quintile of this socioeconomic gradient of all the countries in the world. And you can see a couple things. You can see this huge decline in enteric and respiratory infections, maternal and neonatal disorders, especially in the poorest locations in the world, especially in low SDI locations. These are almost all countries in sub-Saharan Africa, I'll just tell you. You can see the contribution of violent events. So this yellow spike here is the Rwandan genocide, and it gives you a sense of the impact of these socio-political events, wars, natural disasters, these gray spikes here. This is the Haitian earthquake. And then the one before it is the Indian Ocean tsunami. So you get a sense of how these sudden shocks impact mortality globally from natural disaster or war or violence. And then importantly, I was talking before about the decline in cardiovascular disease as one of these great successes of public health over the last couple of decades. And you can see it here. It's all the way over in the high income or high SDI locations, and a couple important features of it. So it's real, and it was a huge decline, but it was only in about 25 countries in the world, right? And so cardiovascular disease burden has increased dramatically in almost every other part of the world, and just in sort of OECD nations for the most part, these highest income countries, have we seen that decline? That's one thing. And the other thing is it's going up again. I mean, it's very clear. We're seeing this in the early mortality results coming in the United States. We're seeing it across many other countries, and we're not exactly sure why. There are a lot of good hypotheses out there, but it's quite clear that this era of dramatic year-on-year declines in cardiovascular disease burden in high-income countries appears to be over. That doesn't mean it's over in every part of those countries, and in fact, that's exactly what we're seeing is this fracturing of the average effect and this explosion of disparity, where some places continue to get much healthier and other places seem to be getting much less healthy. We also spent a lot of time working on risk factor exposures. And so we collect all of the available data in the world on 80+ risk exposures. You can see here from one of our recent papers, just aggregating the trend, the annualized rate of change in these leading risks. So you can see high systolic blood pressure there at the top. These are ranked by their contributions to health. They're colored by the rate of change over the last 30 years, the last 10 years or so. So you can see smoking going down, you can see household air pollution going down dramatically. Actually, the largest decline of all of these risk factors globally over the last 9 years has been in household indoor air pollution due to, we think, the expansion of inexpensive stove technology that decreases the pollution that was accruing from using organic fuels indoors. We can see the decline in child growth failure, a huge risk for later health in life. And that is likely related to improvements in child and maternal health overall. But then you can see, high body mass index going up dramatically, ambient particulate matter, so that's PM 2.5 or air pollution going up quite a bit. And hold on there. And so, this is simply observational or descriptive epidemiology. We're simply showing you the trend that we observe when we take all of the available data on the levels of exposure in different countries and different populations and aggregate them together. It's even more interesting if you tease them apart by these SDI quintiles, right? So this is what I showed you before, where we've taken all the locations and we basically categorized them into low SDI, low, middle, and then high SDI. This is the socioeconomic spectrum of locations in the world. And you can see a couple things. So I told you that smoking is going down, and you can see, thankfully, smoking appears to be going down everywhere. But you can see that there's some differences, right? So we see declines in low birth weight, short gestation period for neonates, and ambient particulate matter, high LDL cholesterol in just high SDI locations for the most part, whereas those risks are continuing to increase over the last 10 years or so in most other parts of the world. So it's really important that sometimes we hear these stories in the literature or in public health or in the popular media about successes in health, that we understand that for the most part, we're often only hearing about trends related to a very, very small number of countries. So just circling all the way back to where we started with Abdel Amran, remember that what he was really talking about with the epidemiologic transition was a demographic transition. And one of the ongoing efforts of the Global Burden of Disease study is to sort of continue that chain of demographic research and update it continuously. And so what you see here is what I would call the most recent snapshot we have for what the demographic transition looks like. So this is the story of where people are aging in the world and how it varies by location. On the x-axis, you can see countries plotted by the percentage of population younger than 15 years of age in that location. And on the y-axis, the percentage of the population that is over the age of 65. All of the red dots are 1950, and all of the blue dots are 2019. So just for example, you can see Japan here, moving all the way up to this far extreme location 70 years later. And there's a huge amount of heterogeneity in the way that populations are changing in terms of their demographic composition over time. And I would say, this was the observation Abdel Amran made. This is what drives patterns of health. And if you're in the position of being a healthcare or health system or Ministry of Health decision maker in a country, this is probably among the most important things that you want to understand. And if you're interested in regional patterns of health, this is what you need to know. And I would say this is something that's even useful in the United States. If you're in charge of health in a county or within a health system with a defined catchment area, you really want to understand these transitions in aging, because they're going to end up driving the demand for health services and the kind of health services that you're going to have to deliver. So I mentioned briefly that we look at global health and national patterns, but we also move down one level and look at state or province level health. But we also have a real interest in exploring even local patterns of health. This is work that we did on county level coronary heart disease death rates in the US. And this is a real interest for my group and others at the Institute for Health Metrics and Evaluation, is to move to this subnational local analysis of patterns of health to keep it updated and to improve the quality of these kinds of estimates. I mean, it's quite apparent, I hope, to most of you, and given where all of you are right now, I don't think I have to tell you this, that even state level is not adequate in the United States. Even county level that I'm showing you here is probably not adequate for a lot of things. And we have to increasingly move to the smallest geographies where we see every time we zoom in, sort of like fractals, we reproduce the amount of disparity that occurs at the high level, to the point where even moving from block to block, neighborhood to neighborhood, we see a lot of variation. This is work that we did in Minneapolis, St. Paul, at the zip code level, looking at using electronic health records, which in Minnesota, all primary care doctors report electronic health record data centrally to a state sort of quasi-governmental quality organization. You can actually answer questions like, how well is hemoglobin A1C controlled for the entire primary care population? And you can see that we can construct these kind of hotspot maps. Anyone who's actually from Minneapolis and St. Paul, I mean, this is the other sort of interesting feature about this approach, is they looked at these results when we showed them to them, and they were completely unimpressed, right? Because these are also look exactly like maps of poverty. But unlike maps of poverty, we can actually update these and track the effect of interventions. And so as we start to play around with using large amounts of data to build these hotspot or small area variation maps, we start to build tools that allow us to say, well, if you actually try and change these patterns, for example, let's say you develop a community health worker-based intervention to improve diabetes control, let's see if these things change. And because you might be doing your evaluation or your measurement for the highest risk location, you can think about how that can drive improved sample size calculations. You might be able to power your studies in really effective ways so you will actually detect a signal from your intervention. The long history of community-based health interventions in the US has been that they don't work. That's starting to change, but a lot of that history came from those studies being done around the wealthier regions where the university faculty lived and did their studies. And so as we move to studying places that are more remote or more impoverished, we have the ability to test interventions that may work better. I know some faculty at your own institution who are leading some of this work, looking at rural health in the South. And it's, I think, a really exciting area for population health in general. I'm also showing here some work that we did on county level mortality, census tract level mortality in Seattle. And this is, again, another important way to move beyond sort of the average effect at a state level or at a county level to begin to think about how policy might be designed to really target the locations where we think disease burden is the highest. So I want to finish off by talking about what are we going to do about this? When you talk about global cardiovascular disease burden, it can sound very overwhelming. It is, the leading source of disease burden in the world, and many of the locations where we observe high levels of cardiovascular disease burden do not have existing modern health systems. And the idea that we might have to build those and then wait, I don't know, 100 years to see the effect can be pretty frustrating. I want to tell you that I think there's some really exciting, tangible, implementable, practical, cost-effective approaches that we're starting to identify, and that there's some really nice opportunities to make a big impact soon. And also that while I'm going to talk mostly about low-income settings in other countries, I think that those are opportunities to think about how to improve health in the US as well. I think that, in fact, when you start to look at the challenges in global health, they are challenges in national health as well. So the first thing I just want to mention to be aware of are what are called the Sustainable Development Goals. You may have heard of the Millennium Development Goals. Those, of course, had to go away at the turn of the millennium. So now the Sustainable Development Goals are the leading global measures for development. And it's the system by which countries are supposed to be targeting their efforts and measuring any improvement. For health, it's Sustainable Development Goal 3. And for non-communicable diseases, it's target 3.4, which is reducing premature mortality by 1/3 by 2030. As a cardiologist, I always look at this one and wish that they had asked us how to draw a QRS on an EKG, because that doesn't look very healthy to me. But setting that aside, I think countries are really struggling with how to do this. I think One thing that the Sustainable Development Goals do not do is give you a clear path of what you should be doing to try and achieve these gains. And so I think there's a huge gap and a huge opportunity to help think about policies that can actually have this scale of impact. This is a trial that many of you may be aware of, but I just think it's really important to share. I think it's one of the strongest studies to try and support a movement towards a polypill or fixed dose combination approach to the management of hypertension. Here in Sri Lanka, they randomized folks to this fixed dose combination or polypill of amlodipine, chlorthalidone, and telmisartan, cheap, well understood, common medications, but packaged together, used simultaneously from the get-go rather than starting a person on one pill and then waiting and turning the dose up over time, using them together at low dose and achieving what turned out here in a short period of time, 24 weeks, to be a 10 millimeter reduction in systolic blood pressure compared to usual care. So these were hospital-based primary care clinics. So maybe not the most resource limited setting, maybe not something you could implement in a place that didn't have a clinic system. But if you do have a clinic system, and obviously in the US we have a clinic system, I mean, looking at this trial, I think we really all have to ask ourselves, why is this not what we do? And I'll tell you, in the US, we generally don't do this. I am increasingly trying to implement this with my patients, but the FDA has been pretty slow to approve fixed dose combinations in the US for blood pressure. I think it's coming now, and some of you may be involved in this work, and there are a couple trials running, and that's good. We do want evidence. There have been a couple trials reported that have been really effective. The long history of fixed dose combinations in the US is that it was a way for the biopharmaceutical industry to extend patent coverage on expensive combinations of drugs you didn't really want to use. And the closet would be filled up with sort of these combinations of pills that, we would teach our evidence-based medical students not to use what, the pharmaceutical reps had left behind. It turns out that actually that is exactly what we should be doing, not giving the meds that the pharmaceutical reps have left behind, but rather using these fixed dose combinations and also building them into a protocol-based approach such that we rapidly get people on low doses of multiple agents. And I think it's pretty hard to argue with a 10 millimeter reduction in blood pressure, given that in many patients who we treat for high blood pressure, we see a 0 millimeter of mercury reduction in blood pressure. So this is just one other study I want to talk about. This, I think, is one of the most interesting because, of course, the biggest challenge in managing hypertension as a risk factor is that many people who are suffering from it live in places where there's just no health system at all. And this was a cluster randomized study. A couple other interesting things about this study: it was done simultaneously in India and China by investigators who worked together. India and China are countries where the military and the political leadership do not get along. They have tanks lined up along their borders facing each other, yet their physicians and scientists were collaborating in this study. And it's a reminder that relationships between scientists have a role in helping to knit together a world that oftentimes these days doesn't always want to work together. In this case, it was a 2x2 design looking at lifestyle modification and a single medication given to individuals for blood pressure. It was not delivered through a health system, but rather a community health worker who visited each home, took people's blood pressure, and then monitored them over time. That community health worker was not a doctor, was not a nurse, had minimal training. They actually trained someone in that community in just a few weeks, and they used an Android app tablet to help guide therapy and allow pharmacists remotely in cities that were quite far away to monitor care. And that's important because, in fact, these places were so remote that even getting visiting nurses or pharmacists to these locations would have been quite challenging. And importantly, they picked the right outcome, because you don't need this kind of study to measure whether lowering blood pressure improves health. We know that is true from other studies. They picked the outcome of just how many people were still on a single drug for blood pressure at the end. The other important thing about this study is they used this cluster randomized design. You could imagine doing this, just implementing the intervention and looking over time. But development is very rapid in a lot of these locations, and the context of these villages is changing, and you wouldn't have known if you were just catching the secular trend. So by actually using this very practical kind of cluster randomization approach, they were able to definitively show that it was their intervention that had this effect. You know, it's interesting to think of these very rural, impoverished communities, but they all have cell reception, right? So there's this disconnect between how rural and poor they are and some of the technologies you can actually implement. Like it's fine to have an Android app-based tablet with cellular data in these locations because everybody has a cell phone now. And if you look, you can actually see, that the improvement was profound. I mean, not 100%, but probably not that far off from what you might see if you enrolled people for blood pressure care, for example, at the county hospital that I work at in Seattle, where we also have a lot of issues with adherence. They were able to do this in a setting without creating any kind of health system. These locations had no clinic, had no doctor at the beginning of these studies, and they had no clinic and no doctor at the end of these studies. They had a community health worker with minimal training who implemented safe, effective care and improved outcomes, we suspect, because they were able to keep people on a once-a-day pill, which is a tough therapy for people to be on. And so we start to see that there are opportunities to try and improve health, even at the end of this muddy dirt track in far northern India or up on the Tibetan plateau, which is where these locations were, very, very quickly. And in fact, a lot of these interventions are now being implemented in those places. You can think about the most rural places in your own community or the places in urban areas even where it's hardest to deliver care and whether these kinds of interventions might actually provide a path forward in those places. Now, one of the biggest challenges for non-communicable diseases and cardiovascular disease in general in global health is funding. And I just want to show you, so this is just a visualization of all of the global health financing flowing from private foundations and countries and what it's going to. And non-communicable diseases gets about 6% of global health funding each year. And so one of the challenges is, I think, helping to communicate to funding countries and other organizations that actually there is a huge mismatch between where they're sending their funds and what health problems they're actually facing. And cardiovascular disease is often a relatively early event in people's lives in these locations, with rates increasing rapidly after age 40. And so these are people who are supporting their families, who are part of the workforce, massive economic implications for people who have heart attacks or strokes or early sudden death. These are not people at the very oldest ages experiencing a natural death from one of these events. Always a lot of this, about a third of these deaths occur before the age of 65. So in summary, high quality data is essential for tracking changes in cardiovascular disease globally, and there's still very large gaps in the available data. When we do look at the sum total story from all of the available data, however, we see huge regional variation in cardiovascular burden and regional risks. Global risk factor targets have to be tailored to that local context and to this capacity of local health systems. And we're just starting to think about how to design the studies that tell us to do that. But there's great opportunities in this area. So for those of you who are just starting your careers, who are thinking about which direction you want to go, you're thinking about the kinds of grants you want to write and the kinds of proposals you want to make for research, we need effective evidence-based health policies. We need to know what the cost-effective interventions are, both in the US and globally. These are areas where there's actually immense interest in funding now from places like NIH and Wellcome Trust, and a range of other funders. What I see is that we actually don't get that many proposals to do this kind of work. And so while it may feel like it's a kind of research different than the traditional kind of biological, laboratory-based medical research that has traditionally been funded in this country, there is both a need, but also an interest in people working in this space, not just around implementation science, which I do think is getting a lot of traction, but policy-oriented implementation science that's designed to drive change for really massive problems that we're going to be facing over the next 100 years in this country and around the world.